Thank you, Dr. Khan, and good evening to everyone. So what I'm going to do is just talk a bit about fortification strategies for attempting to improve growth in preterm infants. If we could go to the next slide. I have no conflicts of interest or financial disclosures to report. Next slide. So I wanted to spend just a few minutes on measuring growth because there has been a lot of discussion in the literature recently over the best methods for reporting growth and for following growth in the NICU. And one of the parameters that is most commonly reported is growth velocity or weight gain velocity in grams per kilogram per day. And so what I'm showing you on this slide is just some data from 4 growth charts, the Babson, the Fenton, and the Olson growth charts, and then some data from Eckhart Ziegler's classic study on the reference fetus that shows the weight gain velocity by week during gestation from 25 to 40 weeks. And the main point of showing this graph is that we have to be aware that the growth velocity starts relatively high with an average of around 17 or 18 grams per kilo per day, but does gradually fall off. And particularly at 37 weeks, there's an abrupt decrease in growth velocity. And it's just important to remember that when looking at the literature, because classically or historically, the goal for growth velocity has been 15 grams per kilo per day. And then more recently with Fenton and Olson's new charts, they recommended, based upon their data, that the average growth velocity was about 16 to 18 grams per kilo per day. And so that became a goal more recently. But although that is valid for more immature babies, for example, between 25 and 36 weeks, the average growth velocity is somewhere around 17 or 18 grams per kilo per day. But if the baby's born later at, for example, 29 weeks and then discharged at 39 weeks, you would really be looking at a growth velocity average of about 14 or 15 grams per kilo per day, depending upon the baby. The other point is that it's also now becoming more common to report changes in Z-scores for a parameter with regard to growth. And just to remind you, a Z-score is based upon the standard deviation from the mean of the average weight at a particular gestational age. So if the baby's weight is 1 standard deviation above the mean for their gestational age, that's a Z-score of +1. And if it's 1 standard deviation below the mean, that's a Z-score of -1. And but looking at this data, the reason I'm pointing it out is that it's common to report the change in Z-score between admission and discharge, or between a certain point when the study begins and the end of the study. But it's very important to look at the groups and be sure that they have the same length of stay and gestational age if you're going to try to compare Z-scores. Because, for example, if you have a group of babies that are admitted at 26 weeks in one group and then discharged at 36 weeks, and the other group was admitted at 26 weeks but didn't get discharged until 38 weeks or so, and if they both have the same growth velocity throughout their hospital stay, the group that is discharged later is going to have an advantage because of this fall off in the growth velocity, which will give them an advantage when you look at the change in Z-score, because they'll be doing some catching up based upon the fact that they're growing at the same growth velocity as the other group. Next slide. So this slide is just looking at it at a little different way. In the first column, these are birth weights, and this is the discharge weight. And this is the growth velocity in grams per kilo per day. And the scenarios are for babies between admitted at 26 weeks and discharged at 37 weeks. And the top 4 rows are for boys and the bottom 4 rows are for girls. And so in the first scenario, a boy is admitted at 26 weeks and then discharged at 37 weeks. And at birth, the baby's birth weight is at the 50th percentile. And then at discharge, the baby's weight has gotten back to the 50th percentile. So the change in Z-score between birth and discharge is zero. And in order to do that, to get back to the growth curve that was designated by the baby's birth weight, the growth velocity would be 16.3 grams per kilo per day. Now, if the baby did not get back to the 50th percentile, but got back to minus 0.8 Z-scores below the 50th percentile, the weight gain velocity required based on the Fenton 2013 data would be 14.6 grams per kilo per day. And I chose this minus 0.8 Z-scores below because there has been a study recently by Rochot et al. That looked at the average fluid loss in the first week or so of life. And what they found was that for a group of preterm babies that they studied, the average weight loss resulted in an adjustment of the growth curve from the weight, the growth curve designated by the baby's birth weight. After weight loss, the curve was decreased by minus 0.8 Z-scores. And so their suggestion is that that's probably a normal goal for allowing for the weight loss due to fluid loss in that first week of life. So that if you were computing the change in Z-score for a baby that was admitted at the 50th percentile and then at discharge was back to minus 0.8 Z-scores, that would be probably relatively normal just by the adjustment due to the fluid loss. And then after the fluid loss, the baby then, if the baby grows along the normal growth curve, you know, that would be normal. And in addition, they showed that if the baby continued on that growth curve that was adjusted down post-discharge, the baby actually would be on the normal WHO growth curve for infants in the first 2 weeks of life. The other scenarios are if the baby was at -1 standard deviation below the mean, or the change in Z-score was -1 between birth and discharge, and then -2. And I chose those just because there is data in the literature now showing that if the change in Z-score is at -2 or more negative than -2, that it is associated with poorer neurodevelopmental outcome. And you can see that the weight gain velocity at that level, if the baby only gained at 11.6 grams per kilo per day, this baby would end up at -2 Z-scores below the mean for the 50th percentile. There's sort of mixed results looking at outcomes between -1 and -2. And then the data on the last 4 rows are for the girls, and you can see that's very similar to what the boys are. Okay, next slide. Today what we're going to talk about is fortification of human milk feedings. And it has been shown that an exclusive human milk diet composed of mother's own breast milk and supplemented with bank donor breast milk and then fortified with a human milk-based fortifier has been shown to decrease the occurrence of necrotizing enterocolitis compared to a diet of mother's own milk supplemented with preterm formula and then fortified with a bovine-based fortifier for infants less than or equal to 1,250 grams birth weight. However, some of the studies have shown poor growth for infants on that exclusive human milk diet. There have been some studies looking at fortifying mother's milk earlier than at the standard 80 to 100 milliliters per kilo per day of enteral feedings. And one study was by Hare et al., which was a cohort study where they started fortifying at 24 calories per ounce with a human milk-based fortifier at 60 mLs per kilo per day. And compared to their historical data, they did see an improvement in growth. However, the Sullivan study, which was the study initially that showed the benefit of the exclusive human milk diet with regard to decreasing necrotizing enterocolitis, had two arms in the exclusive human milk group, one that was fortified initially at 40 mLs per kilo per day, and the other at 100 mLs per kilo per day. And they actually didn't see any difference in growth between the two groups. There have been two studies published using bovine fortifier, one by Tillman, which was it was a retrospective study where they actually began fortifying to 24 calories per ounce on the first day of enteral feedings and compared it to their historical control where they were fortifying at 100 mLs per kilo per day. And then the Shaw study was a randomized control study where they began fortifying at 20 mLs per kilo per day with bovine fortifier and compared it to a group at 100 mLs per kilo per day. And again, neither one of those studies showed improvement in growth, but all of these studies have not found adverse effects from earlier fortification, including no evidence of increase in necrotizing enterocolitis. If we could go to the next slide. So what I'm going to show you today are two studies that we've done. This first one was done at Randall Children's Hospital, and it was actually a study looking at the effect of a feeding protocol on growth for infants less than or equal to 1,250 grams. Or actually this was, in this study, it was less than 1,500 grams. But we did implement earlier fortification as well as a modification of the protocol. So there are three epochs that we looked at: the pre-protocol epoch, the time period when we initiated the protocol, and then a period where we modified the protocol. And the feeding protocol consisted primarily of standardizing the number of days of trophic feedings, of standardizing the advancement rates, and then also we had an algorithm for managing feeding intolerance. You can see with the modified protocol, the difference between the initial protocol and the modified protocol was that we began advancing a little bit faster in the infants greater than 1 kilogram. And we did also begin fortifying initially at 40 to 50 mLs per kilo per day. With regard to the fortifier, in the pre-protocol period, we actually were starting to use the human milk-based fortifier, but just for high-risk infants. And we designated high-risk infants as infants that had a significant patent ductus arteriosus, were less than the 3rd percentile for weight at birth, or had concerning abdominal symptoms prior to being fortified. In the initial protocol period, we continued that approach with regard to the human milk-based fortifier. But in the modified protocol, we started using the human milk-based fortifier for all infants less than or equal to 1,250 grams. You can see that our goals for enteral intake of calories and protein were pretty similar actually throughout this time period. And then in the last 3 rows are the infants that were receiving different diets during these time periods. And the preterm formula group are infants that were receiving mother's milk, but supplemented with preterm formula if out of mother's milk or not able to provide mother's milk, and then fortified with a bovine fortifier. The donor milk group were infants that received their mother's own milk, but were supplemented with bank human donor milk if out of mother's own milk, but still fortified with the bovine fortifier. And then the exclusive human milk group is the group that received mother's milk or donor milk and the human milk-based fortifier. If we could go to the next slide. So this slide is just showing some outcomes. And what I'm showing you is the outcomes for the preterm formula group and the donor milk with bovine fortifier and the exclusive human milk groups after implementation of the protocol. And what you can see is that the infants in the preterm formula group were more mature and of higher birth weight, while the exclusive human milk group was had the lowest birth weight and were the most immature. They also did have a lower weight gain velocity with the donor milk group intermediate and the preterm formula group having the highest weight gain velocity. But with regard to length and head circumference growth velocities, there's really no difference among the groups. As you'd expect, the donor milk and the exclusive human milk groups received a few more days of parenteral nutrition. But looking at outcomes, what you can see is there was no difference with regard to late onset sepsis. There was a higher incidence of chronic lung disease in the exclusive human milk group, but that group, as we've noted, was a little bit more immature and of lower birth weight, and they also were of somewhat higher acuity. But looking at necrotizing enterocolitis, they had the lowest rate of stage 1 as well as stage 2 NAC, with the donor milk group being intermediate, and then the highest rates of NAC being in the preterm formula group. If we could go to the next slide. Looking at the analysis of covariance for growth, what we did find was that the exclusive human milk diet was associated with a lower weight gain velocity, while the preterm formula diet was associated with a higher weight gain velocity. But we also found that fortification, earlier fortification, was associated with a better weight gain as well. And we found that same finding for length, with earlier fortification being associated with a better length gain velocity. For head circumference, the preterm formula group did have a better head circumference gain, but we also found that implementation of the protocol in era 2 was also associated with a better weight gain. And again, when we're looking at the analysis of covariance, we're looking at the whole group of babies in all 3 diets. If we could go to the next slide. And then with regard to clinical outcomes, the only association that was found that was significant was with necrotizing enterocolitis stage 2 to 3, where we found that there was no association with fortification, but there was an association with exclusive human milk group having a significantly lower rate of necrotizing enterocolitis. If we could go to the next slide. This second study is the study that was just recently published in the Journal of Neonatal Medicine on early fortification. If we could go to the next slide. And this study is a retrospective study of infants of 500 to 1,250 grams birth weight at 4 neonatal ICUs whose breast milk feedings were fortified with a human milk-based fortifier at greater than 60 mLs per kilo per day versus those that were fortified initially at enteral feeding volumes less than or equal to 60 mLs per kilo per day. We had the usual exclusion criteria, including those that developed NEC or intestinal perforation prior to milk fortification. The initial fortification with the human milk-based fortifier was at 24 to 26 calories per ounce and continued for at least 3 weeks or until 34 to 35 weeks. And then, and mother's own breast milk was supplemented with a bank donor breast milk. Infants who were fortified at the lower volume, less than or equal to 60 mLs per kilo per day, the early group, were further fortified with the human milk-based fortifier to 26 calories per ounce at 80 to 100 mLs per day.
अच्छा 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 वहीं पे रहो और वो जो है मैं अभी एक लड़के को भेजता हूँ तो मैं फिर कमरे में छोड़ दूँगा ठीक है सारी वो बात करते तुम ही करनी
We get somehow I got muted. Could we go back a slide? Oh, go. Okay, keep. Okay, and then the late group was fortified further at 120 to 130 mLs per kilo per day, and then there was some further fortification if there was growth failure or fluid restriction. Okay, the next slide. No. Okay, the statistical analysis was pretty routine with the univariate analyses. I won't go into a lot of detail on that. And then we did do multivariate analyses as well. Our primary outcomes were weight and head circumference gain velocities, as well as changes in z-scores between birth and discharge for weight and head circumference. And then we also looked at secondary outcomes of NEC, any late infection, chronic lung disease, severe retinopathy of prematurity, or mortality. For the multivariate adjustments, variables, we used birth weight and head circumference, gestational age, gender, SGA status being less than the 10th percentile on the Fenton curve, and then chronic lung disease, parenteral nutrition days, and study site. And actually, when we looked at chronic lung disease, we also included days of mechanical ventilation. If we could go to the next slide. So these results are just for the baseline characteristics. You can see that the early group was a little bit more immature and of lower birth weight, and also had a lower head circumference at birth, but there were no other differences in these baseline characteristics. Next slide. And for clinical outcomes, the only significant difference between the two groups on the univariate analysis was a decreased incidence of chronic lung disease in the early group. And particularly, there was no difference in the incidence statistically with regard to NEC or surgical NEC. If we could go to the next slide. So looking at the nutritional outcomes, as you would expect, the median day of life for fortification initially was day 8 in the early group versus day 12. And the volume of fortification median was 50 mLs per kilo per day versus 96 mLs per kilo per day. There were no differences in discharge weights or z-scores. The only significant difference was with weight gain velocity, which was a little bit higher in the early group at 13.3 grams per kilo per day versus 12.9 grams per kilo per day. And on the univariate analysis, there wasn't a significant difference in head circumference gain. On the next slide. But looking at the linear regression analysis for the whole group, what we did find was that for weight gain velocity and for change in z-scores, there was an association with early fortification with a better weight gain velocity and a less negative change in z-score between birth and discharge. Birth weight and gestational age were also significant factors. Next slide. We found the same result with regard to head circumference, with early fortification being associated with improved head circumference velocity overall, and also a less negative change in z-score between birth and discharge for head circumference. Again, birth, head circumference, and gestational age were important factors as well. If we could go to the next slide. With regard to the clinical outcomes, the only significant finding was with chronic lung disease, where we found that there was a significant decrease in chronic lung disease associated with early fortification. There were some site differences, and then also there was an increased association of chronic lung disease with patent ductus arteriosus and with days of mechanical ventilation, as you would expect. Next slide. So from this study, we found that earlier fortification was associated with a greater growth velocities and less negative changes in z-scores for weight and head circumference for infants less than or equal to 1,250 grams. There was also in this particular study an association with decreased chronic lung disease, but there was no effect on NEC related to early fortification. Next slide. This study is limited because it is a retrospective study, and therefore significant findings are associations and do not prove causation. And there may be other predictors that were not included that can affect growth. And as you saw, there were some site differences, but site differences were included in the multivariate analyses. So there were corrections for that with regard to the possibility of different nutrition support practices. Next slide. This last slide is just showing you sort of the evolution of our incidence of chronic lung disease at Randall Children's Hospital, the unit involved in the first study I discussed in more detail, and comparing it. Randall is a type C bond unit, and type C units are units that have all services, including cardiac surgery. And so I'm comparing the data to the type C units in the bond database. And the red line is the bond 25th percentile, the incidence of NEC at the 25th percentile. So you want to be as low as you can be, obviously, for this parameter. And as you can see, we had this very striking increase in NEC in 2006 and 2007, and that's when we started using the human milk-based fortifier for the high-risk infants. We started using donor milk as a supplement to a preterm formula in mid-2009. We initiated the initial feeding protocol in October of 2011, modified it in October of 2013, as I showed you on the slide of the feeding protocols. Since then, we've done some further modification. We are doing initial fortification at 20 mLs per kilo per day now on day 3 of trophic feedings, and then which we started in 2016, and then 2018 we started doing that increased fortification earlier at 60 mLs per kilo per day. And you can see that our rates of NEC have gone down and are remaining relatively low as we've modified our fortification strategy. We're still looking at our growth outcome for these two changes, still evaluating that. Next slide. I think, yeah, this is just references that for you. And that is it. Thank you.